education, looking at another case study here. I call the three amigos. The three amigos is because these are the amigos that are gone in this family here. We're only going to be talking about this lower area here. We're not going to talk about all the other restorations and decay or spacings or root canals or this patient clearly has a lot of work that had been done. But we're going to just talk simply about how or what you want to do with the wisdom tooth situation and a missing premolar, first molar, and second molar position. But as we do, as all of our case studies, we look at our treatment assessment sheet first and see where we're starting and what we need to do to educate the patient. So I have a green or light green on bone density. I have a orange on facial bone because it's actually gone on these sites. And the bone constriction, I have yellow, detached gingiva yellow. There's nothing about the sinus because it's a lower, and then the eye nerve position is orange. Bone characteristics I have is orange, and the ridge height I also have is yellow. So not too bad, not terribly good. So we're kind of in this in-between stage. I also rate this a little bit more on the skill level of things, maybe a little bit more than, let's say, this is super advanced, because there's a couple of treatment plans you could do here. It definitely takes your skill level up a notch. If you're using the right burrs, you're using the right techniques, at least to get it into the right position. You really only need 2 implants to help this case out. But I put the 3 amigos because 3 teeth are missing and the patient is insisting on trying to restore 3 teeth back, which makes it harder in that second molar position than if you were just to place in the premolar and the molar position here. So let's look at that. Let's look at the CT a little bit closer here. If we look at number 20, that would be right here or so. And you can see our ridge is not so hot. We've lost some bone here, so it becomes more narrow. And if we put an implant in, this is a 4.2. Let's see. Yeah, let's put that in and single that out. You see the foramen here. This is what it would look like here. So we're hugging right up against that. That would be pretty ideal. I wouldn't go too much further away than that from the distal point of that. I do like, see his occlusion looks kind of odd here. You're gonna get, if you want to straighten it out, don't lean it as much like this is leaned. I try to straighten it out, or you can try to do this. I wouldn't recommend doing that. That's a little bit too much. So just keep it about straight if you can. It'd be a little tricky to find the line angle on the premolar front of it. So you got to do an x-ray or something with a pin to kind of factor in exactly your angulation on that. The distal direction, you can measure that and pretty much find that. So here's our bone here. You're going to have to bring it below the crest. The reason why it's an 8 is because I'm going to drop it well below that crestal bone. And this is going to be fairly hard bone going all the way in. You can go a little longer with the implant. Let's say, I think this is an 8. You would do maybe a 10. But your drill sequence is going to come right into the nerve. That just makes me feel a little too nervous, especially it just seems if you do it maybe a sinus burr, maybe no end cutting kind of thing where you go exactly to the length. You're going to have to measure it from this crest of the bone. It becomes a little bit tricky, and I would hate to go a little bit too far on that one. You're really going to cause havoc on that nerve just to get a 10 millimeter. But for those that have a little bit more chutzpah, then maybe we do that. So that's a little bit tricky. If you're going to start this case too, you want to get some sort of round burr or some sort of cupping burr that you can actually get a purchase point here, because it's going to be very hard to like hold that drill on there. They always have these lance burrs. I don't really like those. I think they might do decent on tissue. They don't do very well on bone. So you need some sort of twist drill kind of thing to get that going. I just use like a round burr. I have a round kind of ended burr that is used in a augmentation kit I have, a bone augmentation kit. And then you can kind of scrape like a little boat hole right there so you can get into the medullary bone and then place the implant into that area. So the second implant, I'm going to put an implant in here, and I'm just going to put it as that. So that starts to look a little bit better. We do have that constriction starting to follow here on that lingual shelf, and the facial bone is kind of missing there. That would have normally gone up. But we have good density of bone here, and that is a nice placement. A little bit high. You want to probably drop it a little bit lower, but then you're going to be hitting into the bone, and your drill might deflect a little bit more like this. And that would be okay. You know, implants can accept angulation, but you do want to hug that lingual wall, in my opinion. You want to hit the working cusp of the upper one in a compressive way. So then the third one, if you're inclined to do it. Now remember, you have a primary chewing area between here and actually here. So, you know, well, let's see, move that a little bit more over. So that would be your primary chewing area on the bottom. Will the patient be okay with this? It's hard to say. I personally feel like I'd rather not do a second molar implant, then they have a big gap. If you're going to do the third implant, you definitely want to try to make that into the middle, and then you're adding an implant right here. So you got to find your balance point. And when I'm surgically doing this, what I do is I will actually first address this implant and this implant, and then I narrow my field of centering visually from above. When I have the flap open, I know that osteotomy, I put that in, I know the distance from here, I know that contact, I know the size of the tooth, so I put that implant in, and now I look at my osteotomy, at least a 2 millimeter or 2.2 millimeter osteotomy. Then I look, where do I want to be right in the middle, and I just pick that middle spot, and then I go from there. But that's how I tackle it. Let's look at that second molar position. Even more of a shelf, even more facial bone, just kind of like lapping over. Makes it that much more difficult when you get the drill sequence to know exactly how far down you are. So you got to put a little angle to it. You want to try to stay in the softer bone. As soon as you start really hitting hard bone, you might want to think about stopping the drill sequence. This looks like an 8 to me. Let's see. I think it's an 8 by 4.2. So they're not big implants. So here in this case, you would want to splint these together and make sure you have hygienic pontics on top of those, because you're going to get food collecting right in the buccal vestibule, and that's going to be something that the patient's always going to complain about. Is that food collection down here. I would rather not have a second molar for a more hygienic reason. Food will collect in this buccal vestibule, but then quickly go away. But here's where the patient's going to probably beg and want you to do that second molar, and it always comes down to because of that third molar still in there. And he still has third molars in the uppers too, for some reason. They even did a root canal on one of the third molars, which is totally crazy. So this guy's really stuck on keeping all his teeth for sure. So that's it for this case study. It's a pretty nice one. It's definitely a skill towards advanced level. Got to think about this one a little bit more. You got to make sure you get a good purchase point on them, and you should be very successful here. And look at splitting it so that you can get more stability out of it. Anyway, like us on Facebook and subscribe to us on YouTube, and check in for our live broadcast next time. And